HPV vaccination, increasing first-time acceptance rates at a federally qualified health center. Human papillomavirus, or HPV, is the most common sexually transmitted infection and has been associated with approximately 70% of cervical cancers and 90% of anal genital wart cases. As of 2017, approximately 79 million Americans are infected with HPV and 14 million new cases are reported every year. Infection with HPV will affect almost 80% of sexually active women and 61% of sexually active men during their lifetime. The CDC national target for human HPV vaccination completion by 2020 is 80% of adolescent children between the ages of 13 to 15 years, and failure to meet the Healthy People 2020 goal for HPV vaccination will lead to over 50,000 future cervical cancer cases for today's population of girls ages 12 and younger. There are more than 150 types of HPV that have been identified that cause cervical cancer and infect various other locations of the body, including the genital and oropharyngeal areas. HPV types are delineated between two categories of risk that includes both low and high-risk categories based on their association with cervical cancer. High-risk types HPV 16 and 18 are the most concerning and account for approximately 63% of all HPV-associated cancers, with HPV 16 presenting the highest risk for cancer. The vast majority of both low and high-risk HPV infections do not cause symptoms and heal spontaneously in approximately 2 years. However, persistent infection with the high-risk variety can lead to precursor lesions that can lead to the development of cervical cancer. Given the HPV links to multiple cancers, the CDC has deemed vaccination against HPV to be a public health priority. The human papilloma vaccines have demonstrated the ability to prevent almost 100% of the infections by the vaccine type commonly occurring infections of HPV. Gardasil is a quadrivalent vaccine that covers HPV types 6, 11, 16, and 18, and Gardasil 9 is a 9-valent vaccine that covers HPV types 6, 11, 16, 18, 31, 33, 45, 52, and 58. In 2016, the Advisory Committee on Immunization Practices, or ACIP, updated immunization guidelines that now includes both a 2- and 3-dose vaccine series dependent on the age of the adolescent when the first dose is administered. In general, the vaccines are recommended for both males and females between the ages of 9 and 26 years. Vaccination in the early adolescent years is strongly encouraged because of clinical data that reveals a more rapid antibody response at a younger age and is considered more efficacious if given prior to initial exposure to the HPV virus. Even though disease prevalence and morbidity are high, HPV vaccination rates remain low. Combined rates for males and females who have received 1 dose is 56.1%, 45.4% for 2 or more doses, and 34.9% for all 3 doses. There are several barriers to HPV vaccination. Some of the barriers include the lack of opportunity because children in the recommended age range for HPV vaccination do not frequently schedule preventative visits. Parental misconceptions specific to vaccination, awareness and knowledge of HPV infection, attitudes and beliefs about the HPV vaccine, and misconceptions with regard to the lifetime risk of HPV infection prevent vaccination. Additional barriers that prevent vaccination also include parents' fears about vaccine safety and side effects, negative media surrounding the vaccine, concerns specific to vaccine costs. Parents' fears accepting the vaccine condones risky behavior and often do not see the need for the vaccine because they believe their child is not sexually active. And finally, provider-related barriers, inclusive of significant communication challenges, prevent the vaccine from being offered and accepted. There are a variety of methods to increase vaccination with the HPV vaccine. Primary care providers have the greatest potential to deliver the HPV vaccination prevention strategy due to their unique position in the community where most preventative care services are occurring in the outpatient setting. The impact of combined interventions that involve all members of the healthcare team during a health center visit, as well as interventions at the time that require an integrated team approach, inclusive of all members of the healthcare team, and education for both the parents and caregivers have been shown to make a difference. Some additional methods to increase vaccination have to do with research that support a variety of interventions that have a synergistic effect that result in increased provider vaccine support, improved patient parental attitudes regarding vaccination, and increased immunization acceptance. A variety of efforts inclusive of all members of the healthcare team to send a regular and strong recommendation regarding vaccine benefits and a strong provider recommendation have been shown to make a difference. Data transparency with providers specific to the rates of vaccine acceptance can motivate providers to incorporate methods known to increase vaccine acceptance. Efforts to increase vaccine rates must include a discussion about vaccinating at acute care and follow-up visits, not just well visits. The purpose of the study at the Family Health Network pediatric location is to increase first-time acceptance rates of the HPV vaccine during all visit opportunities for adolescent girls and boys between the ages of 9 and 14 years of age. The research question to be answered is, can a best practice model that includes a synergistic approach and a strong provider recommendation increase first-time acceptance of the recommended HPV vaccine by parents at a pediatric primary care health center? The study will take place at Family Health Network of Central New York, a federally qualified health center. The pediatric health center does approximately 11,000 to 12,000 visits annually. The scope of the study will include a comparison of first-time HPV vaccine acceptance rates of adolescents between the ages of 9 and 14 years at all visit types who are part of the best practice model intervention compared to the period 3 weeks prior to the intervention. Data will be analyzed to determine if the best practice model intervention and a strong provider recommendation resulted in an increase to the first-time acceptance rate of the HPV vaccine for the adolescents 9 to 14 years of age. A variety of methods will be used in the attempt to increase first-time acceptance of the HPV vaccine in eligible children. First will be the implementation of a best practice model that will include pre-visit planning to identify 9 to 14-year-old eligible patients presenting the next day for all visit types who have not received a single dose of the HPV vaccine. Educational brochures will be developed for parents as well as staff protocols and talking points. The development of reminder protocols to increase vaccine series completions will also be developed. Provider education specific to HPV vaccine and research-identified provider barriers to encouraging vaccination will be identified. Providers will be given their individual data specific to their HPV vaccine acceptance rates for their patients. Providers will watch an HPV video documentary called Someone You Love, as well as the development of provider educational information specific to methods to increase vaccine acceptance on the provider's part for their patients. Office staff will be educated in an effort to increase awareness and acceptance of best practice model protocols. Staff will also view the HPV video documentary, Someone You Love. They will be provided the practice's current HPV vaccination rates, and the development of staff protocols specific to their part in the best practice model will be developed. A survey will be provided to parents who both accept and refuse the vaccine for their child in an attempt to gain insight into why parents accept and refuse the HPV vaccination. The research design is inclusive of data collection. Data will be collected for all visit types to determine the first-time HPV vaccination rates for adolescents 9 to 14 years of age for the 3-week period prior to the product intervention. Data will then be collected for all visit types to determine first-time HPV vaccination rates for adolescents 9 to 14 years of age for the 3-week period of the best practice model intervention. The results will be compared to determine the impact of the best practice model intervention. Additionally, a survey instrument will include a survey that will be given to parents who accept first-time vaccination with the HPV for their child after experience with the best practice model, as well as a survey given to parents who decline first-time vaccination with the HPV vaccine for their child after experience with the best practice model intervention. Results will be analyzed to gain insight into factors that impact vaccine acceptance or refusal. The statistics for the 3-week period prior to the best practice model intervention are as follows. There were a total of 112 visits for eligible adolescents 9 to 14 years who had not received a single dose of the HPV vaccination. 51% of the visits were well visits, 21% were follow-up visits, 28% were acute care visits. Of the 112 visits, 23% were private insurance, 74% were Medicaid managed care, 2% were straight Medicaid, and 1% were sliding fee. Of the adolescents who had private insurance, 17% were vaccinated at the time of the visit, and of the adolescents who had Medicaid managed care, 21% were vaccinated at the time of the visit. For the 3-week period prior to the intervention, the greatest number of children vaccinated were 11 and 12-year-olds, accounting for about 67% of the children vaccinated during the period. The vaccine was only accepted at a well visit, with well visit acceptance at approximately 57%. Of the 58 males seen, 21% were vaccinated, and of the 54 females seen, 17% were vaccinated. Finally, looking at vaccination rates by providers, all providers had vaccine acceptance only at the time of a well visit. And despite the fact that the overall acceptance at a well visit is 57%, each provider's acceptance rate averaged between 30 and 40%. The deliverables for this project will include an analysis of data prior to the intervention, an analysis of data after the intervention, comparison of data, provider-specific data, staff education, parent education, the development of a best practice model to increase awareness about HPV disease and vaccine benefits, an improvement of HPV vaccine acceptance rate, and an improvement of vaccine series completion.